important point here, because even if we see a reduced knee, the chances of complications are equally high. And the vascular injury incidence ranges between 4.8% in low velocity injuries to 65% in high velocity injuries, and the overall estimate is about 19%. Peroneal nerve injury has overall incidence of 20%, and it can be as high as 45% when PCL and PLC are injured. Hence, the vigilance for an occult injury is of utmost importance. And 16% of the knee dislocations are also associated with periarticular fractures. Briefly talking about the classification systems of knee dislocation, the initially well accepted one was the classification described by Kennedy et al. It was described in 1963. It was based on the position of tibia with relation to femur. It had basically 5 categories: interior, posterior, lateral, medial, and rotatory. And rotatory further had 4 subtypes. Interior was the most common type, accounting up to 30 to 50% of the total dislocations. It is occurred due to hyperextension injury, either in motor vehicle accidents or sporting injury. And it results in mostly intimal tear of the popliteal artery, and common peroneal nerve injury is common in this type of injuries. And the posterior dislocations are the second most common, usually occurs due to high velocity dashboard injuries, and it has highest rate of vascular complications due to complete rupture of the popliteal artery. The lateral dislocation is third most common, usually 13% of incidence, and it occurs usually ACL, PCL, and MCL are torn when these 3 structures are torn. And the medial dislocation is the least of them all, and usually PCL and PLC are torn. Talking about the rotatory dislocations, the most important and significant one is the posterolateral dislocation, as shown in this picture. It is the most common of the rotational dislocations. It is usually irreducible because the medial femoral condyle ruptures through the anterior medial capsule and gets buttonholed in it, and the medial collateral ligament also gets torn and gets infolded inside the joint, and it is usually irreducible by closed means, hence open reduction is usually required, and it has a typical medial groove or sulcus as seen in this picture. Commonly assessing the classification system by Kennedy et al. It has few advantages, like it is very simple to classify, and it helps in planning the reduction maneuver according to the direction of the displacement. And in posterolateral dislocation, the irreducibility can be predicted also. And in certain types, like interior types has nerve injury, chances of nerve injury, and the posterior type has chances of vascular injury. These things can be predicted according to this classification system. However, there are some serious flaws in this system also, like half of the dislocations that present reduced cannot be classified, nor they can be described as also. And it also does not give any information about the injured structures and for the treatment required, etc. The Kennedy classification system is useful until the knee is reduced. Before and after reduction, it does not have that much role. We have another classification system which is usually used associated with the other systems, like the energy of the injury classification, broadly divided into high energy and low energy injuries. High energy constitute of motor vehicle accident, like dashboard injuries, industrial accident, and fall from heights. Low energy injuries constitute of sports injury mostly, like in football, rugby, skiing, etc., and some minor falls. These two mechanism of injury also help us predict the possible complications in knee dislocations. Other currently widely accepted classification is by Schenk et al., which was later modified by Yu et al. In 1994 and 95. It is the classification which depends upon the structures injured in the knee dislocation. It has broadly 5 types. First is the knee dislocation type 1. In this, either ACL or PCL, only one cruciate is injured, plus any of the collateral can be injured. It constitutes about 12% of the overall injuries. And KD2 is the bicruciate injury. Only the ACL and PCL are injured. The collaterals are intact, and it constitutes about 8.5% of the overall knee dislocations. The most common types are the KD3 type injuries, in which ACL, PCL, bicruciate injuries plus either MCL or lateral collaterals are injured. ACL, PCL plus MCL injury constitute about 41% of the overall dislocations, and ACL, PCL plus lateral collateral constitute about 28% of the overall dislocation. Hence, KD3 injuries are the most common type, and KD4, that is all pan ligamentous injury, ACL, PCL, MCL plus lateral collateral injuries constitute around 11% of the overall injuries. These are also quite rare, and these are quite devastating injuries and very high chances of complications. And the type 5, KD type 5 is the additional fracture on KD 1 to 4 injuries. If any of the classification is associated with fracture, that is fracture dislocation, it is considered knee dislocation type 5. These associated fracture injuries constitute around 16% of the overall injuries. And the latter added classification subtypes are the KDC. That means among these all knee dislocation classification, if extra vascular injury is there, we add C to the above mentioned classification, like KD2. If there is vascular injury, we add C, KD2C. Or if there is KD3, ACL, PCL, KD3M plus C, likewise. And if there is additional neurological injury, we add N as a suffix. The same classification addresses most of the problem faced with knee dislocation classification system, and all of the dislocations can be adequately described using clinical assessment and imaging assessment, and accurate identification of the injured structures and planning for the surgical intervention. This classification helps in planning for the surgical intervention, and it is easier to communicate between the colleagues. And it also predicts the outcome after treatment of the dislocated knees, like KD3M fare better than the KD3L, and KD5 has high complication rate. And when there is associated fracture, major fracture with the dislocation, there is a difficulty in satisfactory ligament reconstruction due to bony injuries. And to conclude, knee dislocations are not as rare as they are considered to be. Knee dislocations are no more just bony malalignment. Assessment of the ligamentous integrity is key to identify reduced dislocation, and vascular complications should be actively sought for in acute cases, and stability and mobility are the keys for good long-term outcome. Thank you. I would like to hand over to Dr. Bijendra.
Okay, thank you, Vidur. It was a really nice presentation. So from participants, do you have any question or any query about the knee dislocation? If you have any, then you can unmute yourself and ask a question.
I have a question to Bidur. Bidur, it was a very nice presentation, very intensive. You started with saying that dislocation, whether it is a bony injury or a soft tissue injury. So what is your conclusion now? Is it a bony injury or a soft tissue injury?
It is a soft tissue injury. It is practically soft tissue injury 100% of times. In only few cases, there is additional bony injury, sir.
You mean to say that if there is a fracture, then it is a bony injury?
No, sir, no. What I mean to say is, if the fractures are like, sometimes it is some avulsion fracture, like PCL avulsion, C-gone fracture, or there is ACL avulsion of the tibial spine, sometimes capsular rim avulsion. These fractures are not considered as fractures. These are basically the ligamentous injury, the extension of the ligamentous injury. The fracture included in the fracture dislocation subtype is the major femoral condyles or tibial condyles fracture, which needed separate bony reconstruction or osteosynthesis, sir. So
So
incidence of those fractures are quite rare, like around 16% only. So the
the
major
type 5.
component is type 5, sir, type 5.
So what do you say then? Type 5 is, it should be already there in the classification. It's a type 5 in a Singh's classification.
Yes, sir.
And the priority should be given to repairing the soft tissue or the body component of that type 5.
I think both should be addressed. Both should be addressed. The first, if fractures are not addressed first, the ligamentous injury, addressing only the ligamentous injury won't help much. So regarding the typical management plan for the fracture dislocation will be discussed in the panel discussion later on, sir. In my opinion, the fracture has to be, if there is a major stability concern, the fracture has to be managed first. When bones are solid, then we go for ligamentous reconstruction.
Of course, I agree. The panelists are there to describe what you are presenting, and that is why I asked you. Like my opinion is, it's a type 5. It's not purely a fractured. It's a bony, not purely a hardcore bony injury. It should be a bony plus ligamentous repair. So a lot of our colleagues might think that this is just a fracture dislocation. We should just repair the fracture, not the soft tissue. So this is a very important point that should be, even in the presentation must be stressed, and definitely we will have a panel discussion on that. I just want to say another thing, like in the Singh's classification, the type 1, let's say the type 1, you said that it has been described that it's either a ACL or a PCL,
Yes,
but
sir.
the collateral is like partial or doesn't fall into a total rupture, isn't it?
Yes, sir.
And there are some people who say that to have a dislocation, you must have a bicruciate or maybe at least two ligaments injured. So should this Singh type 1 should be included in the knee dislocation, because it's not a proper dislocation,
So what I found
Isn't it?
during my research making this presentation was type 1 is actually the criteria for type 1 is one cruciate has to be intact. Only one cruciate is turned. Usually it is ACL. And regarding the collateral, it can be both collateral turn or only one collateral turn. It does not mention about the integrity of the collateral. The only requirement for type 1 is one cruciate has to be intact.
One
So
cruciate has to be intact, but the collateral is not that clearly specified, isn't it?
now, regarding the collateral, it has given up, like it can be injured. It can be both collateral injured. It can be single collateral injured, irrespective of the collateral status. If only one cruciate is intact, then it is type 1, sir. What I found in my research during making this presentation.
Okay.
Maybe other presenters or panelists have their ideas in the topic as well.
I think this is a topic of discussion also.
Yes.
Thank you, Bidur. That's all from me.
Thank you, sir. So any more question or comments from the participants or from our senior faculties? Or if there is no question, then we can move forward. So I think there is no question and comments. So I would like to request my another good friend, Dr. Sunil Singh Thapa, to present on the approach to a case of knee dislocation. Sunil, are you ready?
Yes, I'm ready.
Okay, Sunil, you can share the screen and start your presentation.
Is it visible? So,
yeah, it is visible and you are audible too.
Thank you. I would like to thank Asun as well as all my senior teachers who gave me this opportunity to present in this webinar. Now I'll be presenting on an approach to a case of knee dislocation. And my good friend has already told most of the basic things and the classification system and all about knee dislocation. I'll just go brief on it. Knee dislocation accounts for only 0.02 to 0.2% of orthopedic injury, but it is underreported as 50% of the knee dislocation self-reduced and are misdiagnosed. The first published article on knee dislocation was by Sir Ashley Cooper in 1825. After that, a lot of literature is available. Knee dislocation results in multiligamentous knee injury usually, but all multiligamentous knee injury are not due to knee dislocation. It is more predominantly found in male, active sports player or heavy worker. The most common cause of knee dislocation is a road traffic accident, and they are classified under as a high velocity knee dislocation, And those knee dislocation which occurs with a minor twist injury while playing are classified under low velocity knee dislocation, and both of them accounts for around 90%. But the knee dislocation of special concern is the ultra low velocity knee dislocation, which occurs in an obese patient with a BMI more than 30 with a very simple twist, and are most often misdiagnosed and are missed in a primary situation. So they should be, they come under special consideration. And of all knee dislocation, 5 to 17% are open type, and they occur as a part of polytrauma in as high as 44%. And the most common type of knee dislocation, according to the direction, is anterior type. So whenever you see a case of knee dislocation, usually we should follow a ATLS protocol because it may be a part of polytrauma. So the associated injuries to head, chest, abdomen, and all remote fractures should be addressed. We should look for the gross deformity, swelling, and bruising in a knee, and is easily diagnosed by just clinical inspection in most of the time. And we should assess the neurovascular status of the injured limb, and it should not be assessed just once, it should be repeatedly assessed. Foot pulses and skin color should be monitored and should be compared to the uninjured side. And if the pulses are feeble or not palpable, or if there are any hard signs of ischemia, the ABPA ankle brachial index should be measured. And if it is less than 0.9, then it warrants an angiography. We have to look for a foot drop, which is very common in knee dislocation due to common peroneal nerve injury, and it is most common in KD3L type, and the incidence can be as high as 40%. We have to look for any open wound associated with knee dislocation. Then after, get an anteroposterior and lateral radiograph of the knee. This is important not only to see the direction of dislocation, which will help in the close reduction maneuver, but to see the associated fractures, periarticular fractures in KD5 knee. Should the knee remain dislocated at presentation, it should be reduced immediately under conscious sedation by traction and counter traction method, and the direction of dislocation will guide you the force you should apply. Once the knee is reduced, immobilize the limb in a posterior splint or a brace in its most stable position. There is no exact position in which the knee is stable, but a 30 to 45 degree of knee flexion is desirable so as to oppose the posterior structure, posterior capsular structure, relieve the tension from them, as well as to relieve tension on the popliteal vessels. And if the close reduction fails, sometimes it may fail, then open reduction is required, especially in KD3L type, lateral type dislocation, posterolateral, where the MCL, the medial femoral condyle buttonholes and the MCL gets entrapped inside the joint and it becomes irreducible. Clinically, you can see a pucker sign on the medial side of a knee. Then it is a clear-cut indication that this knee is either not going to reduce or will reduce partially and remain subluxed, and is an indication of one of the indication of open reduction. And extensive surgery may be required to reduce the knee in position. Once the knee is reduced, there are certain situations in which we have to put an external fixator, especially if the knee dislocation is associated with vascular injury and we have to do a vascular repair, then the repair should be protected with an external fixator. In case of open knee dislocation, in case of KD type 5 dislocation, that is the dislocation with fractures, periarticular fractures, and if there is grossly unstable knee after reduction and it cannot, the position cannot be maintained in a splint immediately. Ideally, we should try to use a MRI compatible frame so that we can later on do an MRI and get an idea of the ligamentous structure that are torn around the knee. But it is not feasible always in our situation. And the pin sites should be kept, taking in mind for the future tunnel, and a margin of 10 centimeter above and below the joint line is called a safe side, so that the pin will later on not obstruct or fall on the path of your tunnel preparation while doing the ligamentous reconstruction in future. The vascular injury is the most dreaded complication in a knee dislocation, and its incidence ranges from 4.8 to 64% in some literature and as low as 14% in other literature. The vascular injury may be a complete arterial disruption, or it may be an occlusive thrombosis or an intimal tear. And the key to management of the vascular injury is a high index of clinical suspicion. So whenever the foot pulses are absent or the skin color has changed, the extremity is discolored, and there are hard signs of knee dislocation, hard signs of vascular injury, then it is easier, but sometimes the signs are masked. So whenever you see a knee dislocation, immediately reduce it, check the pulses. If the limb is frankly ischemic, then we have to straightforward rush into the theater for vascular reconstruction. But if the limb is well perfused, see the pulse. If pulses are absent and asymmetrical, then go for a CT angiography. If pulse is present, then also the pulse may be sustained by the collaterals, and the perfusion may not be adequate to sustain the viability of the limb. So it is useful to measure the pressure at the ankle and pressure in the brachial artery, and the index, which is called ankle brachial index. If it is more than 0.9, then we can go for a serial monitoring, because the intimal thrombosis might have been there, and that might not have caused the circulatory impairment initially, which may manifest in 48 to 72 hours once the thrombosis progress. And if ABI is less than 0.9, then it straightforward is an indication for an CT angiography. Sometimes the duplex color ultrasonography may be done in a resource constrained situation. So all patients with acutely ischemic limb must be taken to the operation theater for stabilization using an external fixator with a provision of an angiography and a vascular repair. So before putting an external fixator, so as to prevent the ischemic time, so as to reduce the ischemic time, a vascular bypass should be done temporarily to refuse the limb first, then put an external fixator, get an angio done, then a vascular repair or reconstruction with a prophylactic fasciotomy. Delay dramatically affects the outcome. The residual amputation rates, even after proper vascular surgery, is 10% if it is done early. But if the delay is more than 8 hours, then the amputation rate may be as high as 86%. Common peroneal nerve injury are also frequently associated with knee injury, especially in KD3 type. There is 42% higher chance of common peroneal nerve injury than other type of knee dislocation. And the incidence, by some study, it is shown up to 19%, and other studies show the incidence is up to 25%. And the rate of functional recovery depends upon type of nerve injury. If it is a complete palsy, the recovery is less, just 38%. And if it is a partial palsy, then the recovery can be expected in up to 87% of case. So if you see a common peroneal nerve injury associated with knee dislocation, then we don't have to rush for immediate nerve exploration. We can observe for the recovery. And exploration is indicated if we are primarily repairing the PLC structure or we are reconstructing it, then at that time we have to do a neurolysis. But if the nerve function doesn't recover, then we have to go for either a tendon transfer or a nerve grafting. And nerve grafting is successful in up to 75% case if the nerve graft size is less than 6 centimeters. If larger segment has to be grafted, then the recovery chance is less. And the literature says that if there is no recovery from a complete common peroneal nerve palsy after 3 months of observation, then go for a tibialis posterior tendon transfer to maintain the ankle dorsiflexion, because without the proper ankle dorsiflexion, the later any surgery done in a knee for reconstruction will not have a good functional outcome and patient will not be satisfied. Not only pulse and the nerve, we also have to look for the integrity of the extensor mechanism. Many a time the knee dislocation may be associated with the rupture of either a patellar tendon or the quadriceps tendon. We have to look carefully the level of patella, and the patella may be high up, rising in case of patellar tendon disruption as shown in this picture. And we have to primarily repair or address that rupture of the extensor mechanism while treating the knee dislocation in an acute setup. We also have to look for signs of compartment syndrome, and they have to be addressed even by fasciotomy if they are there. But the more concern to us as an arthroscopic surgeon and more discussion today will be focused on those knee dislocations which are usually missed in acute phase or are a part of a polytrauma, and later on present to us with features of multiligamentous knee injury. And the vigilance is very required in case of a knee dislocation, because they may have been reduced spontaneously or might have been reduced before transfer. So they may present as a normally positioned knee when you first see it. So whenever there is a history of suggestive of knee dislocation, we have to look for other telltale sign, not just the gross deformity, especially in an obese patient and in those with ultra low velocity knee dislocation where they are missed most of the time. We have to look for hemarthrosis And if there is extensive bruising and swelling around the knee with a history of trauma to the knee, then we have to think always that it may be a case of a self-reduced knee dislocation, and that might look apparently normal in a plain X-ray. And because of the painful situation, we may not be able to elicit all those tests in acute setup, and we might miss that injuries. So if you see a recurvectum on passive limb extension, or there is gross varus or valgus laxity in a traumatized knee, then it is sure that this is a case of a knee dislocation. And this ligamentous instability test, except the Latchman test and the test for collaterals at 30 degree of knee flexion, varus and valgus tests, other tests are difficult to elicit and should not be tried vigorously in acute setup. And those knee with a multidirectional instability may easily confuse the examiner whether the knee is, which structure is torn, and whether the knee is in normal or a subluxed position. So coming to multiligamentous knee injury, it has been described that if at least two major ligaments of the knee are torn, then that is called a multiligamentous knee injury, and that is a prerequisite to tell it as a knee dislocation too. And these are complex and challenging entity for both diagnosis, reconstruction, and rehabilitation. A thorough patient history, clinical examination supplemented with MRI and stress radiography are mandatory to identify all injured structure before giving a definitive treatment to the patient. So in an acute phase, if you go for an MRI, then you may see an extensive bruise, hemarthrosis, the structures are not clearly visible. There may be a lot of edema around the knee. We may see the disruption around the medial structure here. The ACL is torn, the lateral structure is gone. And there may be associated fracture, even that can also be predicted in an MRI. There may be avulsion of the fibular styloid and other indirect signs of ligamentous injury like PCL avulsion or tibial spine avulsion in case of ACL injury, or the second fractures, that is an indirect evidence of an ACL injury, or there may be reverse second on the medial side, which indicates an MCL, deep MCL is torn. And these images should be read carefully. But in a chronic phase, once the patient if you do an MRI after the acute phase has subsided, then it may not be clearly sure that the PCL, especially the PCL, and for diagnosing PCL and PLC injury, an MRI done in a late phase may not be very reliable, or sometimes may be confusing, because this structure mimics the structure might have healed partially, and there may be fibrosis, and this may mimic that the structure is intact. In such situation, we may have to go for a stress radiograph, especially for posterior and posterolateral instability. And there are certain criteria and the guidelines given to in measurement in millimeter, that after this value, like if the posterior displacement is more than 12 millimeter in a stress radiograph, then it is a combined complete PCL tear. Then similarly, a varus and valgus stress radiograph has to be done sometime. And there are values like in a varus stress test, if it is more than 4 millimeter of opening compared to the opposite side, then it is a complete PLC injury. Similarly, in a valgus stress, if it is more than 9.8 millimeter of opening compared to the normal side, then that is a complete tear of all medial structures. So stress radiograph has a definite role in case of a missed knee injury, knee dislocation, which is presented later on. So my friend has already told the classification given by Schenck, which is the worldwide used in knee dislocation, and most common type is KD3, and it is seen in age up to 52%. Only one literature suggests that it is KD3L that is more common, but most of them says that KD3M is the most common type of knee dislocation, that is ACL, PCL plus MCL tear. Not only the ligaments are torn, there is fracture, there is injury to the vessel and nerve, but there is concomitant cartilage and meniscal injury associated with knee dislocation, and that predicts the future outcome, the functional outcome, and the future possibility of knee developing osteoarthritis after knee dislocation. And Motsa itself said that up to 37.3% of knee dislocation as a meniscal injury and 28.3% as a cartilage injury. Ritter said the incidence is slightly less, just 15%, but there is another study which says that the incidence is as high as 76% for combined meniscal and chondral injury. So these things should be taken in care, and the injury to the cartilage and meniscus should also be addressed while managing knee dislocation for a better outcome. In a chronic long-standing case, the knee might have gone in a malalignment, especially in PCL injury. There may be varus malalignment, and we may have to do a long-standing film. And if you don't get a proper film and try to reconstruct the ligament before correcting the malalignment, the ligament will fail, the reconstruction will fail, and we have to do a corrective osteotomy before, or it can be done concomitantly with ligament reconstruction. But talking all these, most of the literatures are generated from the Western literature, where there is subspecialties knee center. But in a country like ours, where there is a limited, which we say is a limited resource setting, the special consideration should be taken. And there is a very good article recently published in Asian Journal of Arthroscopy, and one of the co-authors is Sachin Tapasvi, very known to us. And this is that in a limited resource situation, because it takes a longer time for a patient to transfer to the surgical facilities, and we have a limited access to the surgical equipments and training in arthroscopy, and there is lack of allograft and lack of post-operative proper physiotherapy. So we may not get as good outcome as the literature suggests in a Western world, and we may not follow all those literatures and all those treatment modality as suggested. So what should we do? A surgery or a non-surgical management for a knee dislocation? Definitely surgical treatment will improve the patient-reported outcome, and all literature suggests that. But a non-operative treatment, that is by close reduction and splinting, or a close reduction and putting an X-fix, mobilizing later on, and not reconstructing the ligament, is also carried out in patients who are very unfit for surgery, frail or sedentary, or in a very constrained limited resource situation. The meta-analysis by Diamond et al. Shows that the knee surgery for a ligament reconstruction and addressing bony pathology and other after the knee dislocation definitely has a better outcome in terms of range of movement and Lissome score than a non-surgical treatment. So what is to be done, whether a repair or a reconstruction? So Marinian et al. Compared an outcome evaluation study in which he studied on a 52 reconstruction and 28 repair of a cruciate ligament after knee dislocation, and he clearly suggested that the repair group has a higher rate of flexion deficit, more posterior instability, and low return to play after the repair. And there is higher chance of failure rate of repair than reconstruction, especially in PLC injury. And Jesslyn et al. Suggests that the failure rate of PLC repair can as high as 38%, while reconstruction is 9%. So when is the correct time for doing such surgery? This is a topic of debate, and there is no consensus what exactly to treat as an acute or a chronic injury. But most of the authors says acute means less than 3 weeks, that is before scarring and the tissue necrosis sets up. But some authors says in a knee dislocation up to 6 weeks can be an acute phase. And the Levy et al. Reported that there is no major difference in range of motion. Either you do surgery in an acute phase or in a chronic phase. But Motsa says that if you try to do surgical management in an acute phase, the arthrofibrosis rate is high. It can be up to 15.2%, while if it is done in chronic phase, it is 3.8%. So the proponent of the acute repair or reconstruction says that it has facilitated early rehabilitation. Not only that, if we try to stage the reconstruction, it can potentially alter the joint kinematics and increase the risk of graft failure. So acute phase repair or reconstruction of all structure is the essence. But most of the author prefers an staged reconstruction. They repair or reconstruct the extra-articular structure, mainly medial or lateral structure first. Then after a period of time, they go for a cruciate reconstruction, usually 6 to 8 weeks following the first procedure. So there are a comparative study which shows which time is better for doing surgery after multiligamentous knee injury, and this is that the staged surgery has a better subjective outcome than either it is done in acute phase or in a delayed stage. So what graft should we use? The no graft is superior for reconstruction in these injuries. It depends on experience of the surgeon and availability of the graft. The graft available to us are autograft, allograft, and synthetic graft. Allograft and synthetic graft are just a topic of theory for us. We don't use this, not possible in our scenario till now. The autograft available are ipsilateral or contralateral hamstring, bone patellar tendon bone, quadriceps tendon graft, and peroneal longus graft. And they may suffice for reconstruction of all 4 major ligaments after knee dislocation. In meta-analysis by Force et al., in a repair versus reconstruction, there is no difference was reported. Either you do a suture repair or a reconstruction in this injury. All of them up to 77.5% had a good or excellent outcome. So what should we do to address it? For a PLC injury, Selborne used to do an in-mesh repair of all those structures and found a good functional outcome in after 6-year follow-up. Jesselyn and Laprade advocated a hybrid approach to manage this grade 3 PLC injury. They do direct repair with suture anchor or recess technique for avulsion fractures or avulsion injuries, and reconstruction for mid-substance tear or if the structure are stressed. This figure shows a bony avulsion of fibular collateral ligament, avulsed from fibula with soft tissue peel-up, and they are amenable to primary repair with a screw, K-wire or a suture anchor and gives a good outcome. The bony avulsion repair has a good outcome. And if we try to do reconstruction, if it needs reconstruction, then there are different techniques, as we all know. It may be a simple, a classical non-anatomic by Larson, or by creating a double tunnel in a femur that is also again non-anatomical, and or it may be a tibia-based reconstruction by Laprade, which is a complete anatomical reconstruction. And this is a very challenging to do in a case of acute knee dislocation while managing it, because of the risk of tunnel convergence and creating multiple tunnel may be difficult, and the availability of graft is 2 grafts are required. So a simple non-anatomic repair may suffice in such a multiligamentous knee injury situation. For MCL injury, if it is femoral injuries, most of the time it is conserved because we believe it heals. If it is a mid-substance tear, then a repair may be done. For a distal based tibial avulsion, or if there is Steiner's lesion, the MCL is superimposed over the pes tendon, and this lesion will not heal spontaneously, so there needs a primary repair by an open exploration and the repair using a suture anchor or a spike washer. And this MCL repair should be augmented in acute knee dislocation with an internal brace. It is found to be useful for early rehabilitation for providing strength and preserving the acute repair. And this picture shows the same thing, the repair of the medial structures with an internal brace. And in a late phase, if it presents in a late phase, then we have to go for a MCL reconstruction, and this can be done by various techniques. And the failure rate is 20% in a repair compared to 4% in a reconstruction group. For ACL and PCL tear, ACL tear is most of the time mid-substance in case of knee dislocation, and 34% is femoral avulsion, while PCL tear is mostly the femoral avulsion. And repair is possible in acute femoral avulsion of ACL with a good tissue quality, as well as for PCL femoral avulsion. It may be a simple primary repair or a repair with a suture augmentation. And for other type of tear and for late or staged process, the reconstruction is always the treatment of choice, and we usually a single bundle anatomical reconstruction for both. And this transosseous, as previously told, transosseous repair of avulsion of cruciate is a viable option in an acute phase, and this can be done with various suture anchors available, and they can be supported or augmented with a fiber wire as an internal brace. So to summarize this KD3 L type injury, which is again KD3M type injury, which are more common, and this should be usually addressed in acute phase by reconstruction of both cruciate and either repair of the MCL or the lateral structures. The repair is feasible as shown in the table. If there is avulsion injury, the repair is still feasible in acute phase, but once the phase is chronic or in a staged phase, then we always prefer a reconstruction. So a special consideration should be given for KD5 injury, where there is a dislocation associated with periarticular fractures. And this should not be taken just as a simple fractures. The fractures should be addressed first. Staged approach to the fracture fixation first, followed by ligamentous reconstruction after fracture healing. In a primary phase, we may put a knee spanning external fixator to maintain the knee joint reduction and address the periarticular fracture, align the periarticular depression with the screws and, if required, plates. And once the fracture heals, then after some time, we have to go for a staged ligamentous reconstruction. and that will only give a good outcome. If you just give the treatment to the bony injury, the functional outcome will not be good. So there are few considerations in case of multiligamentous knee injury addressing. That is most important is how to avoid tunnel conversions in repairing all those ligaments at the same time, in reconstructing all those ligaments at the same time. So there is an article by Laprade which says that we create at least 3 tunnel on a medial side, medial femoral condyle, 1 for PCL and 2 for superficial MCL 1 and posterior oblique ligament 1. So as to avoid convergence of the tunnel between the SMCL and POL with the PCL tunnel, the SMCL tunnel should be directed 40 degree proximally and 20 to 40 degree anteriorly. And the POL tunnel should also be directed 20 degree proximally and 20 degree anteriorly. On a lateral side, so as to avoid convergence with the ACL tunnel, the FCL and PL popliteus tunnel should be directed 35 to 40 degree anteriorly to reduce convergence with the ACL tunnel. And on a TBL side, we may have to create as high as 4 tunnels, as shown in the picture. One is ACL tunnel, another is tunnel for PCL, another is tunnel for posterolateral corner reconstruction, and another for POL. And while creating a tunnel for POL in a TBL side, usually we target towards the Gordy's tubercle, but in a multiligamentous injury, the POL tunnel should be pointed 15 millimeter medial to the Gordy's tubercle, not along the plane of yellow line, which is done usually along the line of red line, red direction, so as to avoid convergence with the PCL tunnel. Similarly for SMCL, so as to avoid convergence, we have to direct the drilling 30 degree distally. So another important thing is how to tension after creating those all ligament. What is the proper tensioning sequence? And it is also a topic of debate, and different authors suggest a different tensioning sequence. The PCL should be first tightened first to restore the central pivot and tibial step off, and this is followed by all. And then there are proponents which fix PLC first, and other are proponents which will ACL first. And if the biomechanical study says that if in a posterolateral corner deficit knee, if we try to fix ACL first, tension it in an extension, then it will increase the external rotation of a tibia. So they advocate tightening of the PLC after PCL so that there will be no marked external rotation of the leg, and that will alter the joint kinematics if we tighten the ACL first before tightening the before fixing the posterolateral corner. So the best technique is suggested if we can follow is fix the anterolateral bundle of PCL at 90 degree to restore the normal tibial step off, fix posteromedial bundle of PCL in extension, then fix the fibular collateral in 20 to 30 degree of knee flexion with a slight valgus force, followed by rest of the PLC structure in 60 degree of flexion and a neutral rotation, then fix ACL in near full extension, and finally the posteromedial corner. So coming to near conclusion, the tips and tricks during surgery is a proper positioning of the patient so as to allow full flexion and extension of the knee. Ensure that you have an adequate graft available and the graft are of correct length. Start with collateral injury first, because in acute injury, if we try to do arthroscopy first, there may be fluid extravasation, and that may impair visualization and identification of the structure. And tunnel positioning should be anatomic, and we should try to follow those principles as discussed so as to avoid the tunnel convergence. And the fixation and the tensioning sequence must also be followed for getting a proper outcome. So for rehabilitation, the expectation is always a full range of motion, but it is not feasible always. An early protected range of motion is important, and we should aim to gain 0 to 90 degree of knee flexion within first 2 weeks after surgery. And periodization should be done for a physiotherapy with a progressive weight bearing, quadriceps activation, and patella mobility. And in a multiligamentous knee reconstruction, a brace is must to be worn during activities as high as up to a year, and the rehabilitation may take up to 9 to 12 months. And despite very good reconstruction and all those things, return to play at any level of sport is reported to be 59.1%. But for a competitive athletes, the return rate may be as low as 22%, even after best surgery. And the functional rehabilitation is the most important prognostic factor for return to play. And the patient who are less than 40 years of age and those who have a low velocity knee dislocation has a better outcome than that. So to conclude with, knee dislocation is an orthopedic emergency with high risk of vascular injury. Urgent close reduction and vascular assessment is must. chances of missing acute knee dislocation is high because it may be a self-reduced knee dislocation, and in case of polytrauma situation, we may miss it. Multiligamentous knee injury in knee dislocation are complex and challenging. Detailed clinical examination, MRI and stress radiography is needed in managing such case. Repair of the ligament in acute stage and reconstruction in acute or delayed or stage gives a better outcome than non-surgical treatment. These are my references from different journals while presenting this presentation. Thank you.
Thank you, Sunil, for your wonderful presentation. I could request the participants or any senior faculties, if they have any question or comments, they can unmute themselves and speak. So if they have any question or comments.
Vijendra, can I ask a question?
Yeah, Sudeep, sir.
Yeah, Dr. Sunil, I think thank you very much for your extensive lecture for the management. You have really tried to cover most of the aspects of management acute knee dislocation. I have one or two queries. One aspect you said the external fixator is to applied later before then the vascular bypass needs to be done. Why is that? Because without a stabilization, you may have you may try to, I mean, the repair may be damaged. So why you?
No, sir. In that is a temporary bypass. What they do is they explore the vessel first, then they put a shunt that are the plastic tubes like cannula sort of thing, so as to stabilize the circulation first, so as to reduce the ischemia time. Then they give to the vascular surgeon to put a X-fix first. Then they will go for a definitive repair.
Initially, just for the as an emergency.
Yeah. Yes, sir. Just the temporary tubes are placed as a shunt, so as to establish the circulation and to reduce the ischemia time.
What would we suggest, like that is possible only in an institution like teaching or where there are vascular teams are available? But what would you suggest if such thing happens in some hospital where such teams are not available?
So without vascular surgeon, I don't think we can manage this condition. So whenever they are vascular team, we have seen in teaching, we have I myself have also assisted while during my residency in knee dislocation with vascular surgeon, and they do such shunts, and then they allow us to put X-fix, and they come back and then they do the definitive repair.
Another question was, you suggested that for suspected PCL injury or collateral injury, you do stress views. But to be honest, and practical purposes, how often you do these stress views in your?
Sir, I have just tried once or twice.
But does it added benefit compared to clinical judgment?
So for a clinically deficit knee, especially the PCL injury in where there is a lot of confusion, MRI doesn't give a good idea. And for a combined PCL and PLC injury, so as to make us confident that it is a complete rupture of the PCL and that has been shown falsely intact in MRI, and we are not so sure about our clinical test, then definitely the stress radiograph will add up.
Basically, you want to see that really the PCL is functionally working or not.
Intact, type 3, grade 3 PCL or not.
Yeah, I might see repair. It has repaired. It has joined in MRI, but if functional, it's not working functionally.
Yes.
Okay. Thank you.
Thank you.
Sunil,
Yes.
there is a question in chat box about what is the protocol of managing multi-ligament knee injury in your center, and do you repair PLC or reconstruction is done?
So if I have to be honest, before we just used to do a close reduction, put in a splint or an external fixator. Then we used to observe the patient for at least, if we put in a brace or an external fixator for a period of 4 to 6 weeks. After that, we remove the external fixator, try to achieve the range of movement with a physiotherapy, assess what are the ligaments injured. Then we go for usual reconstruction in a late phase. But currently, in acute phase knee dislocation, if we have a gross valgus or varus laxity, and then after we do a primary repair for a PLC avulsion injuries. We have done few. We have not done acute phase reconstruction. We always do a delayed and staged reconstruction, collateral first, and then cruciate.
Thank you, Dr. Sunil. Can you stop your screen?
Thank you.
Share screen.
Sunil, I got one more question on that.
Yes, sir.
On the vascular side, when you are doing a vascular repair, how often would you think about doing a fasciotomy?
Yes, sir. It is routinely done, sir. As a prophylactic fasciotomy, we do it. The vascular surgeon themselves do it, basically.
Yeah, that's important.
Dr. Sunil,
Yes, sir.
as you mentioned about sometime the knee dislocation may be confused to diagnose if it is well reduced. Then how do you suspect clinically that the patient might have dislocated knee, but it has been reduced spontaneously?
So, sir, in an acute scenario, if a patient presents with some trauma to the knee, but we just trauma to the knee and we did an inspection, then if we find a gross hemarthrosis and bruising, extensive bruising in and around knee, but the X-ray, even if it seems the knee is in normal position, then we always have to think that it is a part of a knee dislocation, self-reduced knee dislocation.
And especially in the age,
especially obese patient, females, obese, and if we see a gross recurve abdomen examination and there is gross laxity, varus valgus is grossly lax, then we have to think that it might be a case of reduced knee dislocation.
And in acute setting, you may have difficulty in producing extension or the other tests to be done. But even with the history also, if the patient has got a simple slip-like injuries and unable to bear a weight, and there is a gross swelling immediately, that can also increase the suspicion of multiligamentous injury or knee dislocated, and it is reduced spontaneously.
Yes, sir. And they have been given special consideration as ultra low velocity knee dislocation, especially in obese, and it considered around 10%. And these are the things which are missed more commonly than those which are frank dislocation.
Sunil, I have one question for you.
Thank you.
Okay, you said that like every patient with the suspected any knee dislocations present in your institutions or any centers, then you examine for the vascularity, right?
Yes, sir.
So even if the vascularity is normal, we are supposed to do an ankle brachial index. How often do you do that?
It is a theoretically said. I have not done personally till now, and I don't think that we do practice often, but we must develop a habit of doing it.
This is not especially you have planned for surgery.
No, sir. Even if the pulse is present, it is said that the collateral might have established the pulse, and it is routinely and mandatory to do an ABI. And if it is more than 0.9, then we can be sure and just put a patient under a close observation for 48 to 72 hours, so that there will be no late intimal progressive thrombosis. And if it is less than 0.9, even if the pulse is present and the limb seems to be quite warm, then it is an indication of, if possible, a CT angiography, if not possible, at least a duplex ultrasonography.
I just want to continue with the last what you said. If the ankle brachial index is less than 9 and you have a well perfused limb, this is more of a query, my curiosity than any question. What do the vascular surgeons think about that? Do they go for a embolectomy or any, No,
sir. Most of the time, what we have seen is that it is a routine practice to do a Doppler ultrasonography. And if they show there is patency of a vessel, they don't do anything and they don't take care of the part of that ABI.
And I raise this question because if the circulation is being maintained by the collateral, and we just go on with that later on, there may be a ischemic pains that is a very problematic thing for us. So I was just wondering what the vascular surgeons. I'm very happy to hear from you that you have a very good vascular support in your institute. That is very, very important, and was very surprised that our vascular colleagues are stenting us and giving us more time to put on the external fixator. I congratulate you and your center on taking on up this challenge, because whenever we want to manage a dislocated knee, that is being done, but a support from the vascular department is very, very vital to the success of the treatment of knee dislocation.
Thank you, sir. We have to move forward, and I think all things will be discussed in the panel discussion. So we have to move forward. So we will be moving forward for the panel discussion. And before starting, I would like to thank our expert panelists, Dr. Ishwar Pradhan sir, and Dr. Sudip Manbedde sir, Dr. Vinod Sirchan sir, for taking out time in spite of their busy schedule. Thank you very much, sir. Now I would like to request Dr. Vivek to moderate the session of the panel discussion. Vivek, are you ready?
Yes, Bijendra, I'm ready.
Okay, Vivek.
Give me some time. I'll have to manage this. Okay.
Okay, Vivek.
Okay.
Okay, Vivek.
Bijendra, please admit the new participant. Okay, I will be busy in panel discussion.
Okay, Vivek, I will be doing that.
Okay. So, good morning, respected seniors and colleagues. We are doing repeated webinars. We are doing continuing our academic sessions of Arthroscopy Society of Nepal. Today, we are going to discuss about very complex topic that is very fascinating as well. During residency, whenever we had some dislocation, mainly juniors are very excited that they get a chance to relocate them. But these dislocations are, as Dr. Bidu has already mentioned, not the pure bony injuries. They have so many other injuries within which are not seen on X-rays. So today we will be unfolding these mysteries about the knee dislocation. And to unfold these mysteries, we have our esteemed panelists who have lots of experience of managing these knee dislocation. Dr. Ishwar Pradhan, Dr. Sudip Manbedde, Professor Amit Joshi, and Dr. Vinod Sirchan. Dr. Amit Joshi has some other appointments or other family problems, so he won't be available. He just called us. So today we will be discussing with our remaining three panelists, and I can see so many other senior teachers, so I will be involving them as well in this today's panel discussion. So let us start. In our body, there are so many joints, and among these joints, there are varieties of synovial joints, and one of those varieties is the hinge joint. The elbow joint and the knee joint are both the hinge joint. These hinge joints are relatively unstable joints, but while comparing the elbow joints and the knee joints, the bony anatomy is very atypical. In elbow joints, there is good socket over which the good prominent bone is articulated to make a joint, but the bony architecture of the knee joint is very, very different. The femoral condyle is round shaped, while the tibial plateau is perfectly flat shaped. So this joint is inherently unstable by virtue of its bony anatomy. These joints, knee joint, still all these knee joints, all our knee joints do not dislocate, because these knee joints are stabilized by 4 of the major ligaments which stabilize the knee joint in all 4 directions. But when, because of injuries, if these ligaments are disrupted, there will be dislocation. So this is some insight about how the knee dislocates. So let us start with Ishwar sir first. Sir, knee dislocation or multiligament knee injury. I scrolled through so many internet sites and books. What I found the common thing was the books which discusses more about general orthopedics discusses this topic as knee dislocation, and book which discusses more about sports injury discusses this topic as multiligament injury. What is the good term for you?
Very good question, Vivek. That was what I was raising in the beginning also. You know, like I would. I mean, like when I was practicing, you know, when I started, like you young guys, I thought it was only just knee dislocation, you know, and then now I've been practicing sports arthroscopy, and I feel now it is more of a ligament injury, you know. So even in the first lecture when we started, I was asking Vidur, you know, like there are a lot of overlaps, you know. People were describing that you must have a 2 ligament injury to have a knee dislocation, but if you look it up in the Seng's classification,
we will come to that, sir. We have separate discussion about that. Okay, I'll ask Sudip sir, MLKI or KD, knee dislocation or multiligament knee injury? Sudeep sir, are you there?
You are not, you are muted, Sudeep. Dr. Sudeep, you
Yeah.
are,
I think these two entities cannot be separated. I think in earlier days when we less understood about the multiple ligaments and its integrity, its importance around the knee, then we were basically focused around the bony structures. We thought we reduced the knee and somehow we used to stabilize. I have once done even the Steinman pins across the knee, and that is supposed to be a very, very crude method. But I remember one case I have done in my life. Later on, as the time passed, then we started to understand more and more importance of this, all the substitute structures around the knee. So I would consider knee dislocation primarily apart from the bony, it's basically a multi-ligament injuries. After managing the bony part, we have to consider it as a multi-ligament. So we have to manage accordingly.
So first it is knee dislocation. There must have an episode of knee dislocation. But afterwards, once knee dislocation happens and one reduction has been achieved, it is now a multi-ligament knee injury. So I agree with Sudeep sir that these two identities, these two words cannot be separated. Knee dislocation must be there. And dislocations mean two joint surfaces are out of contact. So knee dislocation must be there. But inherent pathology with the knee dislocation is multi-ligament injury. So first knee dislocation must be there. And afterwards, these knee dislocation cases, chronic knee dislocation, I think is not a good term. Better term is multi-ligament knee injury in the later term. I think panelists will agree with my statement, right, sir?
Yes.
Yeah.
Okay. And as Dr. Sunil and Dr. Bidur has already mentioned, the knee dislocation is very, very rare injury. In literature, it mentioned about 0.02% of all orthopedic injury and 0.5% of all joint dislocation. But as Dr. Sunil and Dr. Bidur has repeatedly highlighted, the knee dislocations are underreported because many of knee dislocation, because of the inherent anatomy of the femoral condyle and tibial plateau, gets spontaneously reduced and they present with normal looking knee joint x-ray in the ER. So many a times these spontaneously reduced knee dislocations are missed. So I want to ask Ishwar sir, how many of knee dislocations you attend in your clinical practice do you see as a knee dislocation, proper knee dislocation, deformed knee dislocation?
very rare, I would say, you know. We are talking about my clinic or the ER, you know, like in the clinic, it's more of the very low, ultra low velocity injuries in fatty ladies which come with a dislocated, which is kind of relocated and already been seen by somebody else and put in a splint. Whereas in the ER, where there are cases now, the trend is that we are having more and more severe polytrauma patients. You know, you have motorbike riders, you know, speeding at whatever speed they like, and they do come here with not just knee dislocation, but with a component of fracture in the proximal tibia or in the distal femur. So that, I think, is what we are missing now here. It has been added in the same classification, you know, type 5. And then there was another discussion somewhere, you know, like I looked up in some of the net videos that people are now coming with a classification where it's not just knee dislocation, but knee dislocation with the fracture in the severe road traffic accident. These are also becoming quite common in our ER rooms in DNB.
Okay. Binod Dai, I have a question. In your clinical practice, I'm sure you are looking so many knee dislocation cases of multi-ligament knee injuries or knee dislocation in your clinics. How common is spontaneously reduced knee dislocation after you elicit the histories?
To be frank, like most of the cases in my emergencies are dealt by the residents, you know. So we get around, I would say around 1 or 2 cases of frank knee dislocation in our emergency in a month. That the spontaneously reduced dislocations, they do come in our OPD. So I would say that, like in my OPD, like I see twice in a week, I see maybe 3 to 4 cases in a month.
Okay. And Binod, I'm continuing with you. When the case of knee dislocation comes, what is the worry you are with these cases? What is the most dangerous complication you are worried about in these cases?
Whether it is spontaneously reduced knee dislocations or the patient presenting with the frank dislocations, the most worrisome thing to me or to my resident is the vascularity of the limb.
Okay.
So we never know that whether these patients will develop the vascular impairment. So they may develop within 72 hours or even a week. They have said that the patient might develop vascular injury because of the low development of the thrombosis, up to the week, these patients might develop the vascular impairment. So most worrisome thing is vascular injury to me.
So I have shown two pictures over down there. These pictures it is the real scenario happened with me. This was the case of road traffic accident, and the patient presented to ER immediately after the accident. What happens is the right side of the limb was injured, there was bleeding, and all of the ER personnel were actively mobilized to do something with that limb. But when I reached there after about half an hour, I saw very pale other limb. The other limb is as pale, papery white, pale. So I thought it might be a spontaneously reduced knee dislocation, and I examined that knee dislocation. It was uh, unstable in all planes. So it was a case of spontaneously reduced knee dislocation and was neglected because there was no external injury. So many of our participants here are general orthopedic surgeons and who regularly deal with these type of injuries, and these injuries, spontaneously reduced knee dislocation may deceive you, may deceive you. Some of these injuries may be associated with the vascular injuries, and they may be life or limb threatening injuries, and this may lead to some medical legal concern as well. So what I wanted to make sure is make sure your feet or patient's feet are okay before evaluating the knee in case of knee dislocation. And when the knee is swollen and when the knee is painful and x-ray is normal, suspect spontaneously reduced knee dislocation and look them. Examine them. Even in acute condition, if you are gentle, you can elicit the Lachman test, valgus and Barrow stress test, and it is very, very helpful. And so this is the message from this slide. So why vascular injury is very common is these vascular structures are very, very closely associated with tibial plateau and femoral condyle. So when the knee dislocation happens, the anatomy is grossly distorted. That's why these injuries are very common. Up to 40% injuries may be there. So I think something about this has already been discussed. Ishwar sir, ABI less than 0.9, how common you do in your practice?
Very rarely.
Very rarely.
Yeah. ABI, it's more of a theoretical thing that is very well described, and people do say that there is an importance of it, but in our hospital it's a very rarely done thing. But I think this is very important that we should be doing it, and it does give a lot of idea in how further we should proceed.
Okay.
I just wanted to say, Vivek, that the picture you showed is like what they call a hardcore clinical damage picture, but ABI index, which is less than 0.9, is a soft core, which needs that you have to have you have to admit the patient, do a constant observation for at least 24-48 hours, and then you might develop later on a complete block, like Dr. Binod Serson said, that this should raise the wire, the antenna, that there is some damage to the vascularity, and keen, detailed observation is needed for that kind of thing. Yeah.
So can I say something?
Yes, Binod.
In continuation with the Ishwar sir's statement regarding your cases, and especially when you have in polytrauma patients with multiple injuries, most of them present with the shock, so they may have bilateral cold extremities, because of the shock. The extremity can be a cold, can be a pale. So having suspicion of knee dislocation with vascular is very important, because if the patient has bilateral cold and even the pulseless, even the pulseless can have a vascular injury. So this is, you have to be suspicious very much. Don't think that because the patient has shock, these limbs are cold and ischemic.
Yes. Okay. So, Vinod, how come you do ABI?
No, we don't have a practice of doing ABI in our center, but it has been reported that this ABI is very much helpful. It has around 100 to 100% of sensitivity and specificity also.
So Vinod, my question is, this does not look so difficult. This does not
Yes,
look so
yes.
time-consuming. Why are not we doing it?
So the practice till now, what we have been doing is like already said by the Dr. Sunil Thapa, is like whenever patient comes and we suspect the vascular disease, we subject them to do a Doppler study, right?
Okay.
And whenever there's something wrong in a Doppler, then we suspect and subject them to the, and we consult the vascular surgeon. Then the vascular surgeon will ask for CT angio and all. But I think we all should be able to do this. But I don't know how reliable it is be done with the stethoscope. But definitely you need a handheld Doppler for that. So maybe
Yes, yes.
we are not accustomed. We orthopedic surgeons are not accustomed to deal these kind of things, and using the vascular Dopplers, even the ultrasounds. We should be doing by ourselves. The ultrasound, the musculoskeletal ultrasound and the Dopplers can be done by orthopedic surgeon as well. So we should learn, and I think we should practice all.
Yes, I think this is one thing. Yes, sir.
Yeah, I think means in my practice, in my thing, I use a gynae. I always get a fetal Doppler, and I do it quite regularly. If I get it, I get the gynae's fetal Doppler and use that on the foot. I always do that.
So Silas, sir,
yeah.
So, sir, my question is, I think among many seniors, you are the only one who regularly use ABI.
Yeah.
So
that was my practice when I was back, and that was that was our practice that way.
Yes, sir. So use of ABI.
Pocket Doppler.
How do you think it has changed your practice, or for example, you didn't use ABI and you use Doppler study? Would it have been made any difference?
I think so. That would raise up the antenna for everyone, because in a normal emergency outside, emergency always has a Doppler in the emergency. They always have a Doppler there. So a Doppler is easily accessible. And if you have you cannot get a pulse, or even if you suspect a thing, you have to document the ABI.
Okay.
It is also a legal necessity.
Yes, I agree with Silas, sir, because
why say in the middle of the night you don't do an ABI and next morning there's an ischemia, then you will be questioned in the court of law.
Yes.
So it's because then I have to react in the middle of the night and get the vascular people up, or get the radiologists up and so that is the practice outside. So we don't do that here. That's different. But because that is easily accessible, and in the court of law, it is important also.
Yes, exactly. I agree with Silas. And this ABI, calculating ankle brachial index, is not so difficult. Doppler, as Silas sir has already mentioned, we can use fetal Dopplers for which fetal Doppler for the calculation of systolic blood pressure of ankle, and we use the stethoscope for the blood pressure of brachial side. So it is not so difficult. It is doable. It can be done in almost every hospital. So I think we should make it a habit in every case of knee dislocation, get ABI done. And if ABI is less than 0.9, then proceed accordingly, involve the vascular surgeons as well for our management plan. So it can be
Dr. Vivek?
Yes, sir.
Can I ask you one question?
Yes, sir.
During your preparation of this presentation, did you go through what is more sensitive, like ABI or Doppler study while diagnosing a vascular injury?
ABI, sir. ABI raises the suspicion. So ABI is very important and each and every review article, each and every article always mention about the ABI, and without ABI, the other vascular interventions are very, very rare. So ABI, I think, is very important.
ABI is the functional one.
Can I just add one here? Like ABI is like, Vivek has shown us two pictures here. ABI done with a Doppler and ABI done with a stethoscope. I also went through how ABI is done. ABI is usually done with a Doppler study, Doppler ultrasound. So if you do a ABI with a Doppler ultrasound, it is like doing a Doppler. So that has to be differentiated. You do not do a ABI with a stethoscope. It's to be done by a Doppler ultrasound. As far as I know, what I have found out.
Yeah, that's what I have found out also. You do with the hand Doppler. So you can be a
absolutely.
sound one.
You have to use
the sound one. You can a color
you have
one.
to use the Doppler above and below.
Yeah, above and below. That's true. And this
we use Doppler.
These Dopplers are usually done to rule out the vascular injury, not to diagnose the vascular injury. You know. So once you subject the angiodiagnosis index is less than 0.9, then you subject this patient for other interventional radiology.
Yes, exactly. That was my point. Yes.
So
in our setup, sometimes it is very difficult to have vascular surgeons at the middle of the night, like Silas sir already mentioned. And if even ABI is not done at that particular time, and if limb becomes ischemic the other day, then it is all our fault. So ABI is doable and ABI should be done, I think.
Yeah, that is the difference. Doing a ABI with a Doppler ultrasound and just doing a Doppler ultrasound is quite totally different.
Yes,
and I just want to bring out this query of mine. You know, maybe Arjun and Sunil can ask also. You know, like they say that they have a very good vascular support team. You know, and this is quite a rarity in our context. You know, in Nepal, I don't know. The concept of a cardiothoracic or a cardiovascular surgeon and a vascular surgeon regarding these peripheral injuries, I find a little bit different. Is that the same with all my colleagues? You know, like, do you usually consult a vascular surgeon for this kind of thing, or do you consult somebody like a cardiovascular or a cardiothoracic surgeon? You know.
These are consulted only if there is a suspected vascular injury.
Yes, sir.
And the type of injury, they are likely to have vascular injury also.
Yeah, I understand, Dr. Arjun, but do you have a proper vascular surgeon or a cardiothoracic surgeon or a cardiovascular surgeon to see your vascular cases?
We have a vascular surgeon also, but we have a MCS program in cardiothoracic surgery. And they look for this type of injuries.
Okay.
So in my center, sir, we don't have vascular surgeon in trauma center, but we have to rely from the Beer hospital. So they are both. They are cardiothoracic and vascular surgeons.
Okay. No, my thought process is that there is a difference between somebody who is a vascular surgeon. For example, in the West, you know, like in UK, maybe Silas can give us some input. There is a difference between a vascular surgeon and a cardiovascular surgeon, you know. Silas, can you enlighten on?
Vascular is a completely different field altogether, and cardiovascular, they stick
but here,
but here it is different.
Yeah, in our institute.
Yes.
But in our institute, those who have done MCH in cardiothoracic surgery, some would like to go for the vascular specialty and some go for the thoracic and so.
Okay.
We didn't have separate vascular specialty like bioacademics.
Okay.
So can I take over, sir?
Just last one question, Vivek, you know, to Arjun. And when was this program started, Arjun? Are there graduates who have already passed out?
Yeah.
When did the first batch pass out?
I don't know exactly, but must be more than 6-7 years or so.
Okay, so most of them are practicing as a both specialty, cardiac,
yeah.
peripheral vascular.
Yeah.
Okay, thank you.
So let us continue with our panel discussion. The knee dislocation is very severe injury, as has already been mentioned. And these knee dislocations are usually maybe associated in 30 to 40% cases with popliteal artery injury or common peroneal nerve injuries. And some of these knee injuries, as Dr. Sunil has already mentioned, maybe high velocity injuries, moderate velocity injuries, or low energy knee dislocation. High velocity knee dislocation are because of road traffic accident, moderate velocity are because of sports injury, and low energy knee dislocations are because of obese patients with minimal injury while twisting his or her knee. So we have to be very careful to deal with the obese patients when they present with the normal looking x-rays with swollen knees and painful knees. Okay, so classification.
Vivek, there is, excuse me, Vivek.
Okay. Vijay, please
there is one question about what are the chances and incidence of redislocation after the reduction of knee? So once you have reduced the knee, and what is the chances and incidence of redislocation?
So I am moderator. I will shoot
Yeah,
this question.
Yeah,
One of my
you pass the question, please.
Iswar sir.
Yeah.
Once the knee is dislocated,
Yeah.
you didn't reconstruct or you didn't do anything. Just manage conservatively for 6 weeks in the slab, and ask the patient to go on. Then what is the chance of redislocation?
I actually can't give you that percentage, but there are certain condition where you have to take the patient to acute surgery. You know, for example, if you have a unstable knee after a dislocation and you examine the patient is tending to redislocate again, then you have to stabilize it. Usually done with an external
that patient has been immobilized for 6 to 8 weeks with slab and then given physiotherapy. Now patient is walking, and what is the chance of redislocation if he suffers some twisting injury again?
Again?
Yes.
That's a big question, you know. I don't know anybody has done a study on that. But yeah, you can always, very rarely I would say that, you know, because it depends upon a lot of things, you know, whatever the ligaments that were injured, you know, how much of a redislocation. Like I said, initially it was still redislocating, you know, you should have stabilized it more with a more rigid fixation, like an external fixator or something like that. But I don't know, you know, like after 6 weeks of immobilization, but of course you have to see that, you know, like even in a long leg back slab or a knee immobilizer, that you have a proper reduction, you know, you don't see whether you are getting a proper reduction, and then after 6 weeks you see, and then it is partially dislocated, then that's not use that's not use worthy at all, you know. So you have to assess your relocation, how stable is that. If you have a dislocatable, then you need to go further than just giving a splint or a plaster. And I like to point out that there are certain cases, you know, of knee dislocation where you need an acute surgery, like this case where it's unstable, where you have an open dislocation, and when you do a vascular repair, you need to put a more rigid external fixator, which was very nicely pointed out by Sunil, I think. Yeah.
Okay, sir.
Vivek,
Vivek, can I add something?
Yes, please.
Yeah. Actually, I would consider immobilizing the knee straight for the 6 week is not a very good idea. Because we have to reevaluate the knee. It's not the question of whether the knee is going for redislocation or not. I think we have, as the knee becomes quiet after maybe 2 weeks, 3 weeks, then we have to assess the integrity of all the ligamentous structures, and straight away immobilizing for 6 weeks. By the time most of the muscles are atrophied, knee becomes stiff, and then we are managing with more difficult problem. I think straight away immobilizing for 6 weeks without assessing the is not a very good
question idea. Question was usually during my residency, as well as Sunil has already mentioned, we used to manage knee dislocation by acute reduction, then maintain that reduction, retain it with external fixator or some form of slab, and keep it for about 6 to 8 weeks, then do gradual physio and ask patient to mobilize accordingly, and we didn't used to reconstruct or anything. So how common is redislocation in these cases? This question is, I think, Sudeep sir and Arjun sir. Arjun sir has seen so many follow-ups of these cases, which we used to reduce in emergency. So
I think Vivek. Okay, Vivek.
Yes.
I think the question exactly asked was, what I understood is like, if the patient had knee dislocation, what is the chance of recurrence like dislocation also? Okay.
Yes.
Redislocation. I mean, okay. Usually patient with a knee dislocation managed conservatively. If there is a instability, the patient will complain of recurrent instability. And so that this sort of patient would like to come for the further management because of this instability complex. And so in a functional point of view, they will be disabled to some extent in their day-to-day activities.
So how common was patients coming with episodes of redislocation in these
I have not, I have not seen any like redislocation, but the rather patient comes with the recurrent instability, features of recurrent instability.
Can I say something?
Yeah, yeah, Binod, please. After Binod, I have another important point to point out yet.
Okay. If you are immobilizing for 6 weeks, then gradually mobilizing, sometimes if the patient has very unstable knee, even in the plaster, it can subluxate. Not a frank dislocation, it can subluxate. And you may get a cases of, subluxated knee, in your follow-ups, but no frank dislocations. But I'll give you my one experience. Recently, I've seen one patient which we had KD5 dislocations. The fractures were fixed in the local center, and he was asked to go to the higher center for the ligament reconstruction. And he came after 3 months of his primary surgery. He had fixed 2 cannulated screws in his lateral condyle, but the knee was dislocated.
Yes.
So that
that was the initially also it was unstable. But here the question is, once the initial dislocation was managed, but what is the chance of redislocation?
So
is it the question, Bijendra?
Yes.
I just want to say here, Vivek, your question is a little bit biased in the sense that, there is not a consensus on treating a dislocated knee, I would say. There are reports that, like that's what I say, I want a vascular opinion also. Even in cases where you have a knee dislocation with a vascular injury and the vascular surgeon repairs it, and then we are very, enthusiastic to do the ligament repair. And there are people in the West who do a ligament reconstruction within 2 weeks, maybe within 3 weeks after even a vascular repair. So what I mean to say is the idea of putting the knee immobilized for 6 weeks after reduction, whether there is a vascular injury or not, is not standard, So you can't say what are the chances of redislocation here.
Okay, Vivek.
So we have to keep in mind that the treatment protocol is still developing for a dislocated knee. In some center where they are focused on treating multiligament, they want to do at least, you have that acute surgery, you have a delayed, and you have this stage surgery. People are still working on it. So we don't have a standard in saying that there are people who also put an external fixator when the knees are unstable, but they put an external fixator where they can move the knee with a knee joint so that the knee movement is not compromised. Okay, so that is what I meant to say here. Thank you.
Okay, Vivek, please come in.
Vivek?
Yes.
Yeah, Ramesh sir want to add or something or want to ask a question or comment. Ramesh sir, are you there, sir?
Thank you. Let me tell you all that I only asked this question about redislocation. I had a bad incidence of seeing 2 cases in my pretty almost a decade of orthopedic practice. And the problem, the patient was treated in periphery. He had a knee dislocation. It was nicely reduced by one of the orthopedic surgeons. Check X-ray was done, pulsation, everything was done. But when the patient went back, and we all know that the plaster, he was treated by a long leg cast, and the plaster was not set before he could go home. And so the patient was discharged, he went back home and got his knee dislocated again. And then he came after next day. And then you can imagine what will happen. So I think Sunil pointed out a very important thing, that you have to be vigilant even after you put a plaster, because the chances of these, as you all have been discussing, I don't do that much of arthroscopy, so much ligament instability. But if we are not careful, just I wanted to add it, if we are not careful, even after application of the plaster, the knee might get dislocated. And when the patient comes after a day or 4 or 5 hours, I don't know what we will have to offer him or her.
Yes,
yeah, that is common. That is common problem. Yeah.
Thank you, Ramesh sir. I have also came across one of these conditions. Knee dislocation was managed conservatively. He was older individual of 50s, and he was asked not to undergo any ligament reconstruction, and he fell down and re-dislocated his knee, and this time he had vascular injury. So at that time he was from far west, and he had to undergo amputation because of that vascular injury. So re-dislocation is very common, and this is one of our cases. This is recurrent knee dislocation, not recurrent patella or recurrent anything. This, even while doing the Lachman test, knee was dislocated. So recurrent dislocation of knee can occur, but I think that is not so common. Okay, let's go on with our.
So I just want to point out here that what Dr. Ramesh Singh also quite rightly pointed out is that this is the reason why we are putting out this discussion forum or a webinar, is that acute dislocation is not a very easy thing. You know, it's a case where we should have high suspicion. It is not a case that we should just reduce and put a cast and send him home.
Yes,
We
yes,
must
yes.
admit, do a keen observation for at least 24-48 hours. This should be taken.
Needs to be admitted.
seriously.
Yeah. The patient needs to be admitted.
Any
Yes.
knee dislocation is a high, red flag. It is not a
Yes,
OPD
yes,
case that
yes,
is to be
agreed, yes.
treated with a cast and sent home. It must be
Yes.
admitted, and keen observation of the neurovascular status, either by a Doppler or a ABI, must be done. This is what
Yes,
we must learn to improve
Yeah.
the treatment for knee
Yeah.
dislocation in our country.
Yeah, that should be
Yeah,
taken
I think we should be vigilant on 3 issues.
Yeah.
Yeah, one issue is, as you said, vascular injury chance is very high, even though it was not present initially. And the second issue is like while immobilizing, it remained subluxated situations. And third situation is this subluxation could be because of other intraarticular injuries, like chondral injuries, fragment that is interposed, that is not allowing to reduce well, or because of interposition of soft tissue also, or the meniscus injury displace that is not allowing for the proper reduction.
Agreed.
And-
Agreed, sir. So, sir, I think we have to proceed, sir.
Yes, please.
Okay. So, sir, this is for you. This is for you. 37 years female. She's from Sindhupalchuk, and she typical history. She is a farmer, and she fell from Ali. So had dislocation at that time.
How tall was the Ali? What was the height of the Ali?
I didn't ask how tall, but but it is typical mechanism of injury in hilly areas of Nepal. They with the load over their head like doko, and they fall down from Ali. So though their weight is very low, because of extra load they carry, they become overweight. So easy dislocations of knee happens even by fall from Ali. So this is the dislocated knee on X-ray.
Yes.
So this knee was reduced. So how to proceed?
Where was this patient from? This patient is from Sindhupalchuk, Okay. So in majority of the cases, like that is why what I said, if it was a very high velocity injury, it would have been difficult to reduce. But if was the reduction done locally at the place or at a hospital?
She came with the dislocated knee.
In the hospital?
Yes. So my question is, will you relocate this knee in ER or OR under anesthesia?
First, I would like to see what is the neurovascular structure, neurovascular status there.
It was intact, sir.
It was intact. So if it was intact, if we have the availability, we should do a Doppler or a Baser, do a Doppler to really see if it is intact or not. Do a comparative study on the other side also. If it is diminished, then it is an emergency. You have to take her to the operating room and do a gentle reduction. You already have the X-ray there.
Yes, sir. The problem is because of dislocated knee, dislocated position of the femur or tibia, the arteries are stressed, and usually the pulse may not be palpable, and pulse becomes palpable. One reduction is achieved.
So if the pulse are already not palpable at the initial, you have to have your vascular surgeon stand by and then take the patient to your operating room. But if you feel that it is palpable by palpation, or if you can find it with a Doppler study, and the duration has not that been long, then you should try a gentle reduction and see. Okay, But I would always want a vascular surgeon on the back of my, on the back in the operating room to make sure that you do not, further damage the vascularity on when you do a reduction.
Sir, my question again is, in this type of knee dislocation with related perfuse knee, that means you can palpate the
Yes.
pulsation. So reduction is to be done in ER or OR. What is the
So
standard?
I think it should be done in a very easy way, not at ER. You must take her to the OT. Okay, you have your anesthetist give a very good anesthesia, relax the muscle, and with just a simple pull, it should come back.
Okay. Any of the panelists who thinks that these needs should be reduced in ER only?
No, it should not.
Yeah, Vivek.
Yes,
I started doing this reduction in ER when I was a medical officer.
okay, sir.
Okay, as you said, it's like a Sindhu Palchuk, that lady was from Dolkha. She also had this knee injury following sleep while carrying a load.
Yes, that was typical injury.
So can I add, Dr. Vivek?
Yes, sir. Yes, sir. Sudeep, sir.
I think for two reasons we should not be done in ER, because if we have a palpable pulses in the limb, there can be intimal damage of the vessels. So if you try to forcefully remanipulate the knee in ER, because without a proper, just we are doing the sedation, you can further damage the vessel. So it is always advisable they should be taken to OR with a proper relaxation, and it should be it should come back to its position with a gentle maneuver. It does not require really force. Usually in ER, your residents tries to use a lot of forces, and usually even in palpable pulses, there can be intimal damage because of the proximally there is a popliteal the hiatus, and the downward there is a soleus hiatus. So both the things, they are tethered and it can further damage. So it should be done OR only, not in the ER, preferably.
Okay. What is the next point, sir?
That's a one point. It should be done ER and with the relaxed, and it should not be tried in emergency.
And then after you do your reduction, you must see how stable it is. You must reassess the vascular status, do a Doppler study, palpate on the both sides. If there is a diminished, but there are no hardcore signs of vascular disturbance, then you can observe and see. If it is not stable, then you might need to put an external fixator to make it stable.
Yes,
Dr. Vivek.
Yes, sir.
But for me, it may not be possible to take the patient to OR all the time, because there can be two situations can be there. One is from hospital side, OT may not be available, and another is patient might be in might not be in the empty stomach, and so that you cannot give a general anesthesia. In that situation, what I do is give a analgesic and some muscle relaxant like diazepam, and so in that situation also we can try to reduce it. And regarding the further injury, intimal injury to the vessels, if you don't give anesthesia, general anesthesia, this muscular contraction, they itself can cause a protective effect to the vessels likely to get injured. If it is vessel muscles are well relaxed, and it is in an unstable situation, that can further cause injury to the vessels. So by my initial attempt, if it is possible, will be in the emergency with minimal anesthesia.
Arjun sir, I totally agree with your statement. Knee only does not dislocate in the areas where the anesthesia facilities are available. Knee dislocates in the very remote areas where.
And this is emergency situation. This should be done as early as possible.
Yes, this is an emergency, and one should not wait for anesthesia, and one should not travel for 6 to 8 hours for waiting for anesthesia so as to relocate the knee. But we are talking about the ideal situation. If the knee dislocation occurs in Kathmandu or any areas, in any urban areas where anesthesia, facility of anesthesia is available, we have to preferably do these reduction under anesthesia because of two reasons. One reason is, as Sudeep sir mentioned, as the muscles are all relaxed and you need to do very little force to relocate the knee, there is little chance of further injuring the vascular structures. And another reason is immediately after reduction, you can assess the ligamentous structure. That is, you can do anteroposterior Lachman test, Barros and valgus stress test, and you can have some idea about the ligaments injured and immobilization to be done necessary accordingly. I think all of our panelists will agree on this, right, sir?
Vivek, so
Yes.
we do this kind of reduction in our emergency OT. We have a separate operation theater in our emergency.
That is the best thing we can have,
Yes,
sir.
and we do there, and we do with the conscious sedation. The only thing we should be very cautious is like how you reduce it. You should not hyperextend it because the knee is already, the distal tibia is already anterior and there is already stretching of the vessels. So if you hyperextend it, like you follow the principles of, the over reduction, correction and reduction. So it may further injure the vessels. So you should avoid hyperextension and these kind of things.
Okay, okay.
Vivek,
so yes, Biju.
There is one question in the chat box that what is the technique of reduction for anterior and posterior dislocation, and about regarding the manipulation of the proximal or distal segment.
Okay. Binod Dai.
Most of the cases, if you are giving a general anesthesia with conscious anesthesia with good sedations and muscle relaxation, then simply a traction will suffice.
Yes. Okay. So if patient is under adequate anesthesia or patient is given some form of sedation, most of the time these dislocations are reducible by simple traction without any maneuvers. Okay, I think that we have answered that question. So while I was raised in, I saw a line in Rockwood Orthopedics that in case of knee dislocation with good palpable pulses as well, we have to admit that patient for about 5 to 7 days because some form of intimal injuries might happen and this may lead to thrombosis. How common is this thing? Arjun sir, how common is this thing? I think you have seen lots of knee dislocation in your practice. How common is this?
Yeah, I have seen one case with my eye, Vivek, that he was around 60 years male from Nuwakot. Okay. He had dislocated knee. It was reduced locally in Tirsuli Hospital. And then with a pain in the swelling, the patient was referred to the TUTS. And they had mentioned as a palpable pulse in the initial manipulations.
Okay.
But by the time patient came to our hospital, he was admitted in the ward. On the next day, the patient had no pulse, had signs and symptoms of vascular insufficiency. And that ultimately went into disarticulations.
So this is yes. This is the message
it
to
can
all
be seen,
participants that getting the knee reduced and maintaining it reduced by any means and discharging the patient is not done. We have to admit that patient, we have to observe, we have to palpate the pulse of that patient in a morning round and evening round, at least for 5 to 7 days, because the unknown intimal injuries of popliteal artery may happen, and this may gradually form the thrombus and lead to the vascular insufficiency. So this
and
is
it's been written in Apply also. Then in first my case, I had gone through that Apply book in library when I saw this patient before manipulation and so it was admitted. That was my first experience of knee dislocation.
Yes, sir. These are two previously used retention technique. Any of the panelists still use these techniques, sir?
I have not put any.
Steinman pin.
No.
Okay.
Once in my life. One
Steinman pin. And external fixator, sir?
Quite often. That is the most easy way to do it.
So message from this slide is putting and cross Steinman pin through the joint is most inhuman thing you can do to the knee joint, because you don't know from where you are passing. You are just seeing x-rays. You might be passing through the ligaments. You might be passing through the cartilage. You are passing through the cartilage. You might be passing through the meniscus. So this is most inhuman thing, and this is not to be done. Better if you
but it's been mentioned in book. Vivek.
Yes, it is.
It's been mentioned in textbook.
Actually, this picture is from Campbell.
Vivek, Vivek, can I say something?
Yes, sir.
Yes, I admit that I have done it, but not in acute case. In chronic cases where the patient presents with 3 or 4 months post dislocation, neglected dislocations, and you open it, you see everything in your eyes,
Yes, yes.
I
In
have done,
that time,
I've done is because the external fixator was, very cumbersome. It was not holding the reduction. And second, we are not very much fortunate to have in, hinge type of external fixator, and also
yes,
I've
of
done
course,
it.
of course.
I admit that I've done it.
Yes, yes. And better to do external fixator than do this inhuman technique. Okay, this was the case. I reduced this case under anesthesia in OR, and immediately after that, I did assessment. And what I found was ACL, PCL was gone, MCL was gone, valgus stress test was positive, and even Barrett's stress test was positive. This is, sorry, Barrett's stress test was positive. So what next? Sure, sir. You have a condition with ACL, PCL, MCL, and PLC injury. What will you do? Acute condition.
Acute?
Acute, low energy,
Yeah.
female, good vascularity, day one.
I think
All
like
ligaments.
there are also multiple of thoughts on how to treat this patient. Some people would want to go stage procedure, but there are people who are also doing a one stage repair or reconstruction of everything here. So in our center, we usually do a ACL, if there is ACL, PCL, this is a ACL, PCL reconstruction that needs to be done. And then you had a PLC, was it?
PLC and MCL. On clinical examination, all four are gone.
Okay. ACL, PCL, and a PLC by a modified, Larson, and a MCL reconstruction with the inherent, the ipsilateral hamstring.
Okay. Any of panelists who will delay the surgery or who will not do surgery first?
It requires a surgery. It cannot be managed without a surgery. But I'm awfully surprised that low velocity injury you are talking about, and that it is a multi-directional injury. Is it possible? I don't know. I have not seen it. The low velocity injury with having ACL, PCL, MCL, and PLC injury. I have not seen such cases in the low velocity injury.
Yes, sir. You can see the condition of the knee joint. There is no any ecchymosis. The knee looks totally okay. But this knee is unstable in all four sides. This was the case.
You are talking about the clinical picture is the day one of this patient?
No,
yes,
no.
Immediately after reduction, I examined this. I'm with the lead apron as well, because I just reduced the case and under CM, and I did I'm doing the clinical exam. This is the day one, sir.
Definitely, I will, in my setup, I am not going to do all the repair on the day one. Maybe I'll wait for 1 or 2 weeks to a proper planning. Maybe I'll do it 3 weeks.
Okay,
and
3 weeks.
First preference, I'm not going to repair the whole thing because it's not possible. But the posterior, my PCL is the most PCL and posterior lateral corners must be managed. And maybe the MCL and ACL can be addressed later on.
Okay. So Sudeep sir is after 3 weeks, Ishwar sir is immediate. So Binod Dai.
Yeah, Vivek, do you have an MRI of this patient?
Yes, I'll show you. Oh, sorry. MRI Rahn basis. Sarotic asa dai ligament.
Okay, there any meniscal issues or not?
No meniscal issues.
Okay, then so in ideal situation, it may not be possible to do in the first stage because the patient's financial conditions, everything has to be taken care of. So I have done these kind of injuries at the earliest of 3 weeks. That's it, and delaying for 2 weeks or 3 weeks, can be unhelpful if you are doing an intra-articular arthroscopy also.
Okay.
So you can reconstruct ACL and PCL, and you can repair the MCL with maybe augmentation. Then you can do an Labra type of or Larson type of PLC reconstruction.
Any insight about repairing or reconstructing the ligaments? Repairing anything or reconstructing?
It depending upon the if it is in bony avulsions, femoral sided avulsions, fibular sided avulsions, both MCLs and even the PLC, then maybe you can do it. But the studies have shown that the lateral structures, they are very poor when you repair it. They fare very poor when you repair it. It's better to reconstruct on the lateral side, but in medial side, yes, of course you can repair.
So these points are always been a controversial matter in case of multi-ligament knee injury. Dr. Sunil has already also mentioned all these points as a controversial topic. Operative versus non-operative, I think this has been answered very nicely by literature nowadays. Operative has always got a good result than non-operative management, except in the conditions where the patient is very comorbid and operative treatment is not possible. Early versus late surgery is very controversial. Some surgeons prefer late surgery, and proponents of late surgery says that capsular tears which are there, capsular seepage which will be there during acute arthroscopy will not be there in late surgery. And early proponents will say that if you do early, there will be good rehabilitation early, there will be no muscle wasting at all, so early surgery is good. Some people recommend repair of the condition, some people recommend reconstruction, and some are in between, like repair some structure and reconstruct some structure. Early simultaneous repair versus stage repair is also a matter of controversy. Dr. Sunil has mentioned the literature which says that stage repair has good result, but there are papers, many papers which shows that early simultaneous repair has better result than stage repair. So this is matter of controversy, but it is, I think, surgeon's choice, surgeon's confidence, whether to do early simultaneous repair or stage repair. But early simultaneous repair does have some advantage, that the MCL, LCL, ACL, PCL, the rehabilitation can be done in very propagated manner, very well crafted manner. And choice of graft is autograft. There is no other way. We can use hamstring, both limbs, the quadriceps, both limb, BPTB, and peroneus. So choice of graft is not a problem. Sequence of graft tensioning, what we usually do is PCL, ACL, then MCL and LCL. So early simultaneous, these matters are controversial, and these matters will be controversial in futures. Another problem, practical problem in these multi-ligament injury is tourniquet time. If you want to do all at once, tourniquet time is the big problem. Any option to manage the tourniquet time? I think, Ishwar sir, you do all at once. Tourniquet time, any idea, any tricks about the management of tourniquet time?
Well, if you decide to do it in the one simultaneous stage, what you can do is you can harvest your graft. You know, you must have a pre-mind plan to do use what graft, and usually you can get away with doing your graft harvesting on a local basis. You know, that would save something like half an hour time, 45 minutes, and then you can proceed just inspection with a without a tourniquet. You know, you can usually do and clean it out, and then as you go on, you start saving. Then when it becomes a little bit bloody, it becomes a red out thing, then you can start using your tourniquet and then proceed with your ACL, PCL, which you know if you have been practicing, which in our center I've seen my people, my guys, you guys been doing it within an 45 minute, half an hour, 45 minutes to 1 hour ACL, PCL. And usually the MCL and the PLC you can do with the tourniquet off, because it's an open procedure. You can do the last PLC or the MLC, middle collaterals, in a tourniquet loosened state. That you know, the main thing, ACL, PCL you can do within an hour, and the graft harvesting on a local injection. You know, you can harvest your peroneal as well as your quad tendon under local anesthesia. The other thing is, like, even before you start putting a tourniquet, you can inject some local into the knee, and that will save you another 10, 15, half an hour time. Yes, although the surgery may take the whole day, 3 hours, 2 hours, but you can shorten your tourniquet time by using local anesthetics, you know, doing a planned what graft for what, and then you can usually do it in a single sitting within a 3 hour surgical time with 1 hour tourniquet time.
Yes, I absolutely agree with Ishwar sir. What we have been doing in our center is we do all ligament at once, and we do early surgery. So while doing such surgeries, number one problem is always the tourniquet time. And what we came out with the idea is we inject the adrenaline. the adrenaline with about 100 ml of NS. We dilute it, 1 ampule of adrenaline in about 100 ml of NS. We dilute it and we inject about 20 ml of this solution into the knee joint and about 10 ml of this solution into the areas where the graft is to be harvested. So we don't inflate the tourniquet, we harvest all the graft, we do diagnostic arthroscopy, we do saving, and only while we make tunnels, we inflate the tourniquet. So by doing, in our experience, by doing this method, we saved at least about 1 hour of tourniquet time by doing this technique. So this is very doable thing, and this is very practical tip that I want to share. Any more tips, sir?
One thing you should be aware of is, since this is an acute injury where you have the capsules and the tissues all torn out, you must be aware of extravasation of the fluid into the out of the joint into the compartment. So the nice thing would be to wrap your proximal, at least distal 2/3 of the leg with a transparent, so that you make sure that the fluid doesn't go down. And also every 10-15 minutes, make sure that you are not putting more fluid into the calf. If you do have that the intramuscular pressure, if the fluid is seeping into the compartment, then you have to be aware to be ready to abandon the procedure. Always, this kind of cases, starting from, dealing with a knee dislocation is a very, very dangerous thing. You have to take risk, but you have to be careful, vigilant doing surgery. Even before surgery, make sure that what we have been repeated here, that you do not lose the reduction and then land up tomorrow morning with a completely, devascularized limb.
Vivek, I have a question. Like,
Yes.
as you mentioned that, the knee dislocations can present 5 or 7 days later with the vascular injury. So how confident you are doing these cases in the first day?
Yes, sir. All these cases which comes to us, we do not do ABI, but we do Doppler studies. Doppler studies, यदि त्यसमा normal भयो भने चाहिँ we take those cases for surgery. We have one incidence where patient was anesthetized, and we thought there was some problem with the limb. Then we got the Doppler and handheld Doppler. We saw the waveform, and it was not normal, and we had to abandon that case. So we had one incidence of that case, but your question is very valid, right? 5 to 7 days हामीले कुर्न पर्छ भनिन्छ, but we have done quite early surgeries as well, but believe me, we had no problem.
Dr. Vivek, how early is early surgery for you? Means how early is in an average? How early you do it?
As early as possible.
On day one, all 4 ligaments.
Even in second day, even in third day, we have done it all 4 ligaments. Yes.
There is no issue of like doing arthroscopy and those capsular tear and all those things written in book is of no meaning.
No.
Not
you will have some extravasation over the proximal thigh, proximal calf, and you have to keep on palpating.
So the literature says in acute knee dislocation you must start with collateral first, so that there is no tissue plate damage.
I'm coming to that. If you keep on palpating those things, and if you find that your calf is some tense, then what we do is we open the lateral side or medial side wherever injured, and it acts as a fasciotomy. It acts as the fluid comes out that, and the tension decreases. We have done quite often that thing.
No. What I mean to say is that in a literature it is written, while you are addressing a multiligamentous injury in an acute knee setup, start with collateral first.
No.
Because once you start to do arthroscopy, like you are doing
that is very controversial, right?
Like you are doing a diagnostic arthroscopy first, and insufflating a lot of fluid first, then harvesting a graft, and then again going inside and outside.
Yes. Sunil, please listen. That is very controversial topic. Some surgeons prefer that the cornea should be addressed first, then the center. But what we have been doing 2 years back, I was doing fellowship. I saw then also, and nowadays also we are doing that thing. I used to do that thing in the Lihel as well. We scope inside, we finish all things inside and then we go outside. So I think we have no problem with that. It's all the surgeon's preference. And this matter is very, very controversial. Whatever literature you have studied is, I think the corners first literature is also there, PCL first literatures are also there. So one thing is either you have to do PCL first or corners first, but there is nothing like this has to be done.
Thing is,
Nothing
have you reconstructed all primarily or repaired collateral and reconstructed cruciate?
We have, what we have done is so whenever we do repair, like most of times we had the conditions where MCL are repairable, but we don't leave those as it is. We augment as well. We augment with some tendons. And I think in my experience, it is not of long experience, but all 4 ligaments has been reconstructed only once. And that was the case with ISO.
So what were your grafts then?
We have many grafts. The quadriceps with or without bone, and then peroneus, then MCL, then hamstring. So MCL is always by whip technique, our whip technique. Then PCL is by peroneus longus, and ACL is by the quadriceps.
Okay.
And lateral corner?
Lateral corner we have done only once. We have done only once all 4 ligaments, and at that time we took the hamstring of opposite side.
Opposite side.
Yes.
Okay, can I just comment here?
Dr. Vivek and Ishwar, I have a question for both of you.
Yes, sir.
You are talking in a situation where you have a setup like this, but here we are trying to convey a message to the
I totally agree, sir.
Okay, so let us not say what you are doing in your setup.
Yes, sir.
Let me ask my question. Okay. First of all, you say you can do this kind of cases in a day 1, day 2. Basically, our topic of discussion is knee dislocation, where there can be a subtle way of vascular injury which may not be seen on day 1. There can be intimal damage. Dr. Arjun has said that so if you do in the day 1 or day 2 of this extensive procedure, again you are applying tourniquet, and if you find after this, if you have find after 2-3 days some amount of vascular insufficiency, how are you going to explain the patients?
Yeah.
Normally, is it advisable to do it on day 1, day 2? It's not a technical aspect.
Yeah.
How practical it is.
Yeah. Normally, I also agree. Like there is a lot of controversy in how to manage the dislocated knee and the subsequent ligaments also. But I agree that with the fact that we have to be observant on any case of knee dislocation, not take it so lightly. We have to take it seriously. What Vivek has presented was not a generalized case, only 1 or 2 cases we have been doing. And also the reports have also said that there are better results when you do it in a single stage. That we do not say that everybody should be doing. Of course, the standard teaching is, like Sunil's pointed out, that you go from the extra articular ligaments, then stabilize the PCL, and then you may or may not need to do a ACL also. We would not like to generalize that we are doing it every year, but there are people around the world, like I said before, like even after a vascular repair, if the vascular surgeon is confident, they would let their colleague do their ligament reconstruction within 2 or 3 weeks. There are reports, and there are reports of also some Italian people, group of Italian surgeons who are doing all their acute dislocation multi-ligament repair at one setting, and they are coming up with their standard things. This is a rising science, I would say there are a lot of controversial. Yes. We do not mean to say that it should be generalized, but if you have a proper background, like I said, I always feel dealing with knee dislocation cases with a vascular surgeon behind me, you have to have that, but we can just say that we need to improve on what we are doing. Of course, there will be risk needs to be undermined, but we should not generalize, I would say. Okay, I think Vivek, we are pretty up in the time, and our moderator, Dr. Bizendra, is there. Are there any questions?
Yes, sir, I am there, sir. There is no question till now in the chat box, sir.
I think I just wanted to show this. This was I waited for about 4 weeks. This was case I did in Dulikal. I waited for 4 weeks, and after that, MCL was healed itself. So conservative management of MCL was helpful in this case, and 3 ligaments was reconstructed at once in this case. This was the final result. And I think I have 3 more cases, but we have to wrap up.
So Vivek, before that, we should to convey the message that some of the ligaments they do heal in the conservative treatment.
Yes. That was my question.
Reconstructing 4 ligament is not a joke. It's costs huge amount to the patients, financial burden to the patient. If we can reduce 1 or 2 ligament by conservative treatment, then financial burden will decrease also. So we have to think about
why I included this particular case was because of that only, right? If we wait, it's not that we don't wait means we are always right, but if we wait, I think some of ligaments might be managed conservatively, but there are some group of patients who are very active and who needs very active life from very early on, which may be delayed if we immobilize those cases for about 6 weeks of immobilization. So for those active individuals, I think we can do early surgery, even repair or reconstruct the MCL. But in many of cases, the MCL may be conservatively managed, and we will be repairing or reconstructing only 3 remaining ligaments. I think that is the message I want to convey with this slide.
Okay, there are some questions there in the chat box. I just want to go through it. I think we replied to what Dr. Ramesh Singh was saying. What about redislocation after reduction? But there is another. In suspected knee dislocation, if pulses are palpable at ER, do you go to CT angio? This also has been dealt with.
Yes, I think all the questions have been answered, sir.
So I think that if they have been all answered.
Yes,
I can see Nagmani as well. He also deals with so many knee dislocation. Nagmani, I think all 4 ligament disrupted. Have you seen?
Yeah, quite a few. One of them was with all of us, right? And yes. All the four ligaments were disrupted, and we actually reconstructed all 4. But yes. This guy, I still remember we landed up doing 2 times arthropibrolysis, and because of the stiff knee later on. And yes. Now he has full range, but that guy was affording, so we didn't have a problem. Then there is this, you remember, sir, the 88 years old yes, grandpa. He had four ligaments which were torn, and his knee was moving everywhere in all directions. So we landed up reconstructing, and right now he has 110 degrees of range of motion, sir. And we're using the fixation post. That case we'll be reporting soon, sir. So I don't think so 4 ligament is a contraindication. Rather, we need to stabilize it if the person is functional.
Nagmani, can I tell you on that? As you put in the answer yourself, actually. You've done arthropibrolysis 2 times. There's literature, ma'am, there is very well documented that if you do it early, the chances of arthropibrosis is higher in those patients. Yeah? So that may be an indication, because there's no difference between doing early or late, and we also don't know whether 3 weeks is early or 6 weeks is early.
Yes, absolutely.
Saila sir, I'm telling you that regarding one of the cases where I found complication in which we operated for 4 ligaments. Yeah. But in those with 3, 2 or more, we've done almost around, we are publishing a series which is of 80 cases. And we're doing a follow-up, sir, of 2 years minimum. That's why we are waiting to publish it. We just found 5 or 6 cases with arthropibrosis. Yeah. So I think, and we operate invariably in almost all, unless there is a vascular injury in acute setting.
Outside literature, isn't it? The literature outside says that if you do it early, there's more arthropibrosis. If you do it late, the chances of arthropibrosis is less.
Yes.
That is
okay, sir. Let's end up, sir. Wrap up, sir.
Yeah, I think we should be wrapping up. I think it was a very good discussion, this dislocation of the knee management is quite pretty controversial, and there are people who want early, who want 1 stage, who want to do it in a stage way, but there is nothing wrong to it. It all depends upon what kind of service you can provide to your patient. and lot of thing counts, economics, your expertise, your backing up. I think this is a field that is still exploring, and people are doing that. And what we have to think is that the best we should provide to the patient. And I think we have completed everything here. Sailas, do you want to say anything? And Dr. Sudeep and Dr. Binod?
I think just to say thank you to everyone. I think at the end of the day, it's just important to keep in your mind that knee dislocation is not a simple issue. And we have to take it carefully. There are people who do it early, but in our setting, what is in your setting is the safest thing to do. Yeah. And there is no rush into doing anything. Vascularity is important. I would consider CT angio at the drop of a hat if the thing can be done. That is a very safe way of taking. Safety is the first, surgery is second. Yeah, and don't forget about the shock ATLS guidelines. That is the must, whatever comes in between. Yeah. So
Thank you,
first, limb second. I think that's all we have to say. I think to wrap up this whole thing, we have a next session coming up in 2 weeks.
Yeah, I think Dr. Sudeep is wanting to say something.
No, I think we have covered most of the things.
Yes.
And there was a good take-home message for all of us. So thank you, Dr. Vivek, and everyone for this wonderful session. We always learn many things from.
Dr. Binod?
Thank you, everyone. We had a good learning experience today. This is very controversial topics, not in our setup also, even in the West, everywhere. So it's an evolving science. So we should keep up with the science and learn together. Thank you very much.
Thank you.
Thank you for participating.
I just want to thank Dr. Sunil and Dr. Bidur for their excellent presentation. We want people like you to present more and more, so we older guys can sit back and see and learn. And this was a very nice Saturday evening. We finished quite well on time at only 20 minutes overshoot, but we have the whole day to enjoy. Please enjoy your Saturday. Okay, Sailas, have a good ride. You're going out for your bicycle ride now?
I've gone in the morning.
Oh, very good. That was a good modification. But okay, thank you guys. Thank you everybody.
Don't get quarantined.
Thank you everybody for participating. See you very soon next time.
Thank you, sir.
Okay, thank you. Bye.
Thank you,
Thank you
Arjun.
very much.
Okay, bye.